Hello. This is one of at least a couple chapters. I think it's going to be two, maybe three chapters of systemic lupus erythema. I'm going to share my screen and we can get into the meat and potatoes of this particular diagnosis. I'm going to let you know that there are 3 slides of case study questions to help you process the information that's in this slideshow. So please do yourself some study favors and access these case study questions and either fill them out while I'm talking, or after you've watched my videos, swing back through and complete them to help increase your understanding about what's going on. So in terms of pathophysiology, this particular process is a multi-system inflammatory autoimmune disease. So it's going to do a systemic sort of whole body sort of reaction. It's it has a complex start. It has partly to do with genes, it has partly to do with hormones, it has partly to do with environment, and then there's immunologic pathologies with it as well. It affects so many different things. It affects the entire body. So skin, joints, serous membranes like the pleural membrane that surrounds our lungs, and the pericardium that surrounds our heart. It affects the kidneys, it affects the heme system, it affects the neurologic system. And it does have an unpredictable course with periods of remission and worsening. So what will happen is, and there's the waxing and waning, but instead of that waxing when it's more than a flare, because that flare actually advances the disease process. So it's not just like a flare in terms of the same stuff comes back. It's the flare is worse than the last one. So it's just like 2 steps forward, 1 step back, but in a different way, in a negative way. And in the United States, about 1.5 million people have SLE. It is more common in Blacks, Asian Americans, Hispanics, and Native Americans than it is in whites. And 90% of the people who have lupus are women ages 15 to 45 years. The etiology, it's an unknown cause of this immune response, and it's sometimes referred to as a type 3 hypersensitivity response. The most probable causes, we think at this point in time, the best evidence we have right now, is there's a genetic influence. There's a high prevalence among family members. Hormones seem to play a part as far as menses, oral contraceptives, and pregnancy. Environmental factors such as sun, UV light, stress, chemicals, toxins, infectious agents, and then drugs like procainamide, hydralazine, quinidine, and others can trigger this immune response. What happens at the cellular level with this particular disease process is there are autoantibodies made against the DNA, the erythrocytes, coagulation proteins, lymphocytes, platelets, and other proteins. So these autoimmune reactions, these anti-nuclear antibodies, are directed against cell nucleus, especially DNA. And there are circulating immune complexes deposited in the capillary membranes of the kidneys, the heart, the skin, the brain, and the joints. So these overly aggressive autoimmune responses are related to the activation of the B and the T cells, and the B and the T cells are attacking the DNA of the actual body. They're not attacking like the DNA of like a virus or a bacteria like they normally would. The B and the T cells are actually going after the body. Severity of lupus can be really variable. So it can be mild all the way up to a rapidly progressing disease that affects many body systems. It most commonly affects the skin, the muscles, the lining of the lungs, the lining of the heart, that pericardium, the pleurum, nervous tissue and kidneys. And so generalized symptoms include fever, weight loss, joint pain, excessive fatigue, and then these are kind of like the flags for a worsening disease time. Here is a diagram of the different involvement of SLE. So we'll have problems with the integument, the cardio, the neuro, the heme, and notice that there are multiple points underneath each of these particular systems, and there's not a system that's not affected. Like, it affects the entire body. So there are some different clinical manifestations and complications. The derm is affected by having skin lesions and a butterfly rash. You can have chronic cutaneous lupus. You can have subacute cutaneous lupus. There are oropharyngeal problems. People lose their hair. They have a dry, itchy, atrophied scalp. Here's that butterfly rash. If you can, as you can see here, I'm going to grab a pen. We have a rash here, and it goes like this, like here, here. Come on, pen. There we go. Here, 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 and then back around. And I don't draw very well with my mouse, but you can kind of see where we're kind of coming up with this butterfly rash sort of presentation on the skin. Other manifestations include polyarthralgia with morning sickness, arthritis, increased risk of bone loss and fracture. Here's that swan neck deformity that we saw in RA as well. We can have that here too. There are cardiopulmonary problems. Lupus can really bang on the heart. We'll have problems with increased respirators, cough, pleurisy, which is inflammation and painful pleuric lining of the thoracic cavity. It can cause dysrhythmias. It can cause inflammation in that pericardium. It can cause inflammation in the actual heart muscle itself. It can cause endocarditis, which is another part of the heart. It can cause antiphospholipid syndrome. It creates renal problems where you can have minor proteinuria, but that protein is really hard to process on the kidneys. So then the kidneys get really cranky and sick. It creates scarring, permanent damage that can lead to end-stage renal disease. So a person with lupus can end up in the dialysis unit if things are not handled the right way. Goal is to slow the progression of nephropathy and preserve renal function. And there are effective treatments available, such as corticosteroids, cytotoxic agents, and immunosuppressive agents. Those aren't without their side effects, though. Nervous system problems, people can have seizures. They can have peripheral neuropathy. They have disordered thinking. They can cause cognitive dysfunction, psychiatric disorders, stroke, meningitis, headache, causes problems in the blood with anemia, leukopenia, thrombocytopenia, coagulation disorders. Warfarin is contraindicated for these people because that's a hypercoagulation, so they may be on warfarin. Sorry about that. These people are increasingly susceptible to infections for a few different reasons. They have immunosuppressing drugs on board. They have anti-inflammatory drugs on board, and because their kidneys are always getting damaged from the disease process itself, they have problems eliminating invading bacteria. They have deficient production of antibodies, and then pneumonia is their most common infection. These people should not be receiving live vaccines if they're getting corticosteroids or any sort of cytotoxic drugs. Diagnostic studies, there really isn't a specific test, so we do a lot of related tests. An H&P, a history and physical examination. ANA antibodies are present in 97% of the people. We'll do a CBC to take a look at how their heme is, how's their white blood cell count. How are their eosinophils? How are their lymphocytes? How are, that whole sort of inflammation, infection cascade? How are they doing that way? We'll take a look at their serum complement. We'll take a look at the urinalysis to see how their kidneys are holding up. We'll also do x-rays of any affected joints. We'll do a chest x-ray to make sure that they're not having any sort of enlarged heart or problems with their pleura, and then an EKG for their heart as well. Major challenge, and then I'm going to stop after interprofessional care. The major challenge is to manage that active disease, yet prevent treatment complications that create tissue damage. We need to give them enough to manage the disease, but not so much that we actually do more harm than good. This very delicate balance between doing too much and not doing enough. And survival of these people is influenced by age, race, gender. Socioeconomic status is huge. Any sort of comorbid conditions that they have as well, the severity of the disease. Early diagnosis and effective treatment, of course, is going to be influencing the survival rate. The drugs that we use to help these people out, NSAIDs can be used for the mild joint pain. We may be using anti-malarial drugs. They can cause fatigue, joint problems, but they also reduce flares. So corticosteroids are used in severe cutaneous SLE, and then immunosuppressant drugs suppress the immune system and decrease that end organ damage, but they make them that much more susceptible to infections. So again, it's that delicate balance. We can also have topical immunomodulators. So those people who have that butterfly rash, or they're having cutaneous on their skin sort of expressions of their lupus, we can actually, there's topical stuff that we can put on those that alter the immune response and help with the skin integrity. And then disease management is monitored by serial anti-DNA titers and serum complement. So we're going to be looking at the erythrocyte sedimentation rate and the CRP, the C-reactive proteins, on these particular patients a great deal. We're going to be monitoring them to be able to make sure things are moving in the right direction. So I'm going to stop sharing and I'm going to stop recording and call this a chapter, and then I'm going to move into nursing management for the next chapter. All right, nursing management. Let me share my screen. There we go. All right. So I just finished off with the interprofessional care. Let's talk about nursing management. So our subjective data, what are they telling us? How are they with exposure to UV light? People who have lupus are extremely photosensitive, and Dracula probably had lupus in terms of this sort of photosensitivity. Like, it's awful. It's truly awful. How are they exposed to any sort of drugs or chemicals or viruses? How does their body stand up to being stressed out? Are they having any sort of increased estrogen activity? What is their pattern of remissions and flares? Like, how does that look for them? We'll take a look at their medications, such as oral contraceptives, which contain estrogen, procainamide, hydralazine, any sort of anti-seizure meds, antibiotics, corticosteroids, NSAIDs. Come on, advance. There we go. We'll look at their functional health patterns as well. So how is their health perception and their health management? Do they have lupus in their family? Do they seem to be getting sick more than the average bear? How's their energy to do things? How are they suffering from malaise and impact on functional ability? Do they just not have enough get up and get things done? Nutritionally, they will have weight loss because they're not processing things correctly. They will also have a tendency for skin integrity problems, such as ulcers or ulcers in their stomach, nausea and vomiting, dry mouth, dysphagia, problems with swallowing, photosensitivity and infections. They may have decreased urinary output. They may have constipation, or they could have diarrhea. GI impacts. How is their activity? Are they having morning stiffness? Are they having joint swelling? Are they noticing any deformities? Are they finding themselves short of breath? Are they finding themselves fatigued? How's their sleep? Are they having vision problems, vertigo, headaches? Are they having jointful or painful joints, arthralgia, painful joints? Chest pain, abdominal pain. Are their fingers cold? Are they painful? Are they numb? Are they tingly? Are they having neuropathy? Are they having problems with temperature? Are they having their period? Are they having irregular periods? How is their coping and their stress tolerance? Are they withdrawn from their normal activities? Are they having depressive episodes? Are they having depression? As far as our objective stuff, we're going to be looking for fever. We're going to be looking for lymphadenopathy, swollen lymph nodes, periorbital edema, swollen eyes, or swelling around the eyes rather. Integument, do they have alopecia? Are they losing their hair? Do they have dry scalp? Are they having really dry eyes? Keratoconjunctivitis, that butterfly rash they had talked about in manifestations. Are they having any sort of erythema? Like, are they having any sort of palmar, like, do they have reddened palms? Hives, erythema of the nails, the purpura, the petechiae, leg ulcers, like how is their integument in general? Respiratory, we may be able to hear a pleural friction rub because their pleura is inflamed. We may have decreased breath sounds because the lungs just can't expand because of all of the inflammation in the pleura. Cardiovascular, we may see some vasculitis, which is inflamed vessels. We may hear a pericardial friction rub when we're listening to the heart tones. Hypertension is common. Edema, swelling in the periphery. Dysrhythmias, this can definitely impact the electrical conductivity of the heart. They may have that Raynaud's syndrome that I had talked about in RA, where their hands get cold, they go white, and not far before frostbite. But normally when our hands and fingers get cold, they get red. People with Raynaud's, they get white fingertips and white toe tips. Gastrointestinal, they may have oral and pharyngeal ulcers due to the tissue integrity problems associated with things. They may have splenomegaly. The spleen is working really overtime to process any sort of set erythrocytes, etc. Neurologic, then facial weakness. They may have peripheral neuropathies. They may not be able to have that sensation that we would associate with people who do not have lupus. Papilledema, dysarthria, painful joints, confusion, hallucinations, disorientation, psychosis, seizures, expressive aphasia, either problems saying stuff or receiving verbal information, and then hemiparesis. They may be paralyzed on one side or the other. As far as objective data continuing, we may have problems with musculoskeletal, such as myopathy or arthritis. There will be protein in the urine because the kidneys are getting attacked by those T cells and B cells. We may also find in their, when we're taking a look at different other possible findings, like from the lab, anti-DNA, anemia, leukopenia, thrombocytopenia, elevated erythrocyte sedimentation rate, serum creatinine. We may find blood in the urine. We may find casts in the urine, which are those little squiggly like protein bits in the urine. We can also find pleural effusion on chest x-ray and pericarditis on chest x-ray as well. So nursing diagnoses for these people, they're tired. They have extreme fatigue because their T cells and their B cells are fighting all the DNA in the body. That's a big war. That's a huge war. It's bound to make you tired. Impaired tissue integrity because the DNA is getting attacked, and difficulty coping. Planning. Our overall goals is to have acceptable pain management, show awareness of and avoid activities that worsen the disease, and maintain optimal role function and positive self-image. As you can imagine, these people are definitely subjected, or it could be very easily to have disturbed body image, people who are working against with lupus. So when it comes to implementation, lupus can be pretty unpredictable. So that's challenging in itself. The other thing, and it's not challenging only for them, but it can be challenging for us on the interdisciplinary team. Psychological, physical, and sociocultural problems require long-term management from the interprofessional team. Disease flares can happen very quickly. We'll need to assess fever, limitations of motion, location, degree of discomfort, and fatigue. Monitoring INOs, monitoring weight, especially if they're on corticosteroids. We may have them collect a 24-hour urine to see how their kidneys are handling all of this. We're going to be having them observe for bleeding. We're going to be assessing neurologic status, such as visual problems, headaches, seizures, personality changes, memory loss, psychosis, peripheral neuropathy. And then patient education is really well explained in 64-18, but just to keep you on track here, they need to know the nature of the disease, the treatments, the diagnostic procedures. This is definitely sometimes the more they know, the better they feel that they can have management over their disease process. They need to understand their drug therapy, the use, the administration, and the side effects. People with this condition need to have be really involved in their success, in their home management to have success. Patients understand that strong adherence and treatment is no guarantee against flares. We can't really prevent flares, unfortunately. But if we can reduce the exposure to precipitating factors and work with them on an effective regimen, hopefully we can either reduce the severity and the number or both of those flares. Again, like we said earlier in the presentation, or in the the chapter 1 of lupus, it affects 90% of the people with lupus are women of childbearing age. Therefore, talk about pregnancy is appropriate. Infertility can occur from a few different ways, either from renal involvement, from high dose corticosteroids, and from those immunosuppressive drugs that they're taking. Between the disease process and the therapeutic regimen that we've designed, or that we work with the interdisciplinary team to design, it can create spontaneous abortion, stillbirths, and intrauterine growth retardation are really common for people who have SLE. Renal and CV and respiratory and central nervous systems may be affected during pregnancy already. If the potential mom already knows she has SLE, this is a really hard conversation to have, but perhaps pregnancy isn't her best option in terms of having the outcome that she wants to have for her child. Planning pregnancy when disease activity is minimal, like if we can do and make things work as best as they possibly can, let's do that. However, we need to also have mom be aware that flares are really common postpartum, so she can get through the pregnancy successfully, but then she's going to have some pretty big problems afterwards. And if for whatever reason, if mom becomes pregnant and decides to have therapeutic abortion, that doesn't necessarily reduce that risk of postpartum flare. So mom should be aware of that as well. This creates psychosocial issues for a lot of different reasons. Informing patient and caregiver that SLE has good prognosis for most people is vital, but we need to stress the importance of planning recreational and occupational activities. So maybe a physically stressful position is not necessarily something that a person with lupus needs to be undertaking in terms of a career goal. Maybe they need to take a look at and make some changes with their career goals to be able to be as successful as they can be. We'll work with patients to develop goals. I mean, patients have the right to they have the right to self-determination, right? And then pregnancy and sexual counseling. Like I said, patients have the right to self-determination, and we can give them some great evidence and some great education about things, but ultimately it's going to be their decision. And our job as patient advocates is to help them support them. So evaluation, expected outcomes. We'll work with them to use energy conservation techniques, adapting lifestyle to their current energy. Hopefully we can help them maintain that skin integrity with the use of topical treatments, and preventing disease flare with the use of sunscreens and limited sun exposure. These people, when they get exposed to the sun, it really can create and trigger big problems. And here is an audience response question. So I will be quiet and let you read. I'm going to advance the slide. Hit pause if you need to think about it a little bit more about your possible answer. And yes, all of these laboratory and tests, the anti-DNA, the anti-nuclear bodies, and that anti-Smith in the blood are characteristics of lupus. All right, so here's something that I'd like you to consider in terms of psychosocial needs for the majority of the people who are diagnosed with lupus. What would it be like to tell someone that she can't have children? Or that if she decides to become pregnant, she may have huge likelihood of spontaneous abortion, stillbirth, or a child with severe birth defects? How would you approach having that conversation? And what can or should you do? Our job as nurses is to have these hard conversations. It's not something that we put off for somebody else to do. We don't refer them to psychiatry or psychologists or counselors. This is within our scope of practice. So this is a tough diagnosis for people to work through, and we need to be their advocates while they're working through it. I'm going to stop sharing. That is the last of systemic lupus. I hope you are having a pretty good day, and feel free to, because this is part of an asynchronous lesson, I understand that we're not going to be able to really get together and talk about some of the things that I put into the slides. So be sure to reach out and we can definitely talk about questions or thoughts that you have about the 3 different disease processes that I put together for the learning for this particular week. So have a great rest of your day, and we will see you soon.